So I thank you again, Coach Tiffany. Very appropriate follow up to what he talked about. I think a lot of what Coach Tiffany talked about was mentorship and creating the right culture through the right mentorship and setting the right culture for your program. And I get to share this talk. I gave this talk at the Hand Society for the Dave Green Mentorship Award lecture, and many of my faculty have heard this, and fellows, and some of the hand surgeons there. But I wanted to share a version of this with the alumni and with our residents because they haven't heard this yet. But this is sort of the way I have understood what a mentor is and how my teaching style has changed. And we've seen different teaching formats used so far today. And I can tell you that being an effective teacher is one of the hardest things to do for a variety of reasons. And I want to share this. And I also want to recognize so many people have mentored me throughout my life. So it would take me an entire day to go over, talk about the mentors that I've had. But I want to point out a few that have had a really impactful, or have been really impactful to me in my life. So no disclosure. So I've had one job. So I've worked at UVA Health my entire career. I did med school and residency here. I went away for fellowship for a little over a year. And then I came back because Dr. Wong gave me a job. Of course, Dr. Wong gave me a job. And then when I got back, he had already left. So it was a little bit of a different expectation, or different. It was a change that I wasn't expecting. But I'm very proud of this, the fact that I have really been in one position that I've loved and I've thrived in despite a lot of obstacles. Now, all of you know about me, and I'm not putting this slide up to say, hey, look at all what I've accomplished. I think you can look at this slide and say, oh, wow, he doesn't know how to say no to anything. And that's probably one of my problems here. But I've served in every possible role at the School of Medicine, the Physicians Group, and the Medical Center, and a bunch of boards over the years. And a lot of that has been because I was asked to do things and I accomplished things. But a lot of these roles helped me push this building and get this building approved and opened. I was at the table and I was at the board meetings, and I was able to advocate for my faculty, my patients, my team members. And being at the table is critical for success. A lot of people just don't want to get involved. And I can tell you that if you don't get involved, particularly in your work environment, you will not be able to control or have an input in it, and you will eventually lose autonomy, which leads to incredible disengagement and incredible unhappiness at work. So getting involved is critical, but all of that success came with a significant cost. And many of you have heard me talk about some of the physical and mental issues that I've had, the stress on my family and the difficulty it's been early in my career. I lost a lot of friendships or just ignored friendships, and I had a change in career plan. And the hardest thing is work-life balance. And whenever I reached an issue where I didn't understand what to do and I felt out of balance, I would reach out to my mentors. And there's two parts to this talk: mentorship and then teaching. And I want to first focus on the mentorship part of it and what a mentor is and how you define a mentor. So what is a mentor? Everyone says they're a mentor, right? Or they're mentored by someone, but do you really know what a mentor is? So what is a mentor? And I'm going to read some of this stuff, and there's some busy slides coming up, but focus on the highlighted areas. So mentorship is a mutually beneficial professional relationship in which an experienced individual, the mentor, imparts knowledge, expertise, and wisdom to a less experienced person, the mentee, while simultaneously honing their mentoring skills. So in a mentor-mentee relationship, the mentor actually gets something out of being the mentor. If you don't get something out of the relationship, it's not a good relationship, and you are not an effective mentor. You should be learning as a mentor just as much as you are influencing your mentee. A mentor should always have the mentee's best interest in mind and tailor their mentorship style to meet the needs of the mentee. So one of the themes in this talk is going to be the mentor or the teacher has to evolve. The learner or the mentee does not. We have to adjust the way we mentor and teach to be effective mentors and teachers. And this may be a foreign concept to a lot of people, but I'll explain this more as I get further along. And everyone says they're a mentor, but in many scenarios, they're actually a coach. So what's the difference between coaching and mentorship? Coaching is a short-term personal relationship between two people in which the coach uses thought-provoking creative strategies to help a client develop personally or professionally. Okay, I've actually had several coaches that I paid for during my career to help me with specific situations that I was struggling with. And I'll recognize those individuals. Mentorship is a longer relationship. It's more than a year, and it's, again, mutually beneficial. I think, and Dave Green, my mentor, said to me, I learn from every fellow that I train. And I'm like, how can that be possible? You are the father of hand surgery in the world, and you've written the textbooks on hand surgery. How am I going to teach you something? But that's the relationship that has to develop. It has to be mutually beneficial. And again, the mentor helps the mentee develop professional skills, and the mentee allows the mentor to develop their leadership skills. So you want to be in that relationship where you as the mentor are developing leadership skills. How do you find a mentor? I have a lot of med students and residents come to me, ask me to be their mentor. And I often question, am I the right person for you as a mentor? So the first step is finding a mentor defining what you want out of your career. My career and what I've done is maybe not what you want. So I'm not going to be an effective mentor for you. So it means planning out your whole career, which is hard to do, and consider a career path and narrow it to determine what type of job you want and who you would most admire and who would you like to emulate from a career standpoint. And you can emulate people from a personal standpoint too, but I'm talking here from a career. So the successful mentoring relationship happens when the mentor and mentee are the right match. There are some very poor matches, and that's why the relationship may be ineffective, or that's why the mentee may not progress like they hoped. Reach out to someone who you think you're comfortable with and who can be a neutral sounding board and who also provide great advice. Now, Bill Driscoll is a business person. A lot of this work comes out of the business literature. And I learned a lot of this at Darden. So finding the right mentor is not a secret to success. It's as obvious as it is essential. Someone older and wiser who mentors you is invaluable, whether you've just started your first job or you're halfway through your career. And the one thing I need to emphasize is a mentor-mentee relationship should be a long-lasting relationship. What do you look for in the qualities of a mentor? Experience and success, authenticity, empathy, creativity, and honesty, and similar values to your own. If you have a problem with the supposed mentor you're choosing because of a value standpoint, you may want to reconsider that because it will be an unsuccessful relationship. Great mentors have a complementary skill set and bring different qualities to the table. Different perspectives are important in a mentor-mentee relationship. You don't want to go to someone who just approves everything you're doing. You want someone who challenges you and questions you and is devil's advocate to what you're planning to do, because that's how you actually have success and develop a strong, long-lasting relationship. So this is one of my favorite quotes. A great mentor is someone whose qualities make up a better version of who you envision yourself to become. Okay, I want you to read that again, but that's what a great mentor is. And that's residents, fellows, young faculty. This is who you should be looking for as a mentor. And that's Dave Green, who I did fellowship and my mentor. So a successful mentor motivates you, provides advice, celebrates your success, gives you direction when you're lost, coaches you at times through difficult situations for the short term, provides support, helps you define your goal, and then trains you in areas where you need help. So to me, this is what a successful mentor does. A coach, which a lot of you think you have a mentor when you actually have a coach, because they're helping you through one short situation. That's much different than being a successful mentor. There's types of mentors. Mentor one is the master of their craft. We have several mentors here who fill that role. Mentor two is the champion of your cause, someone who's your biggest fan. Mentor three is the co-pilot. They're with you and they're learning as much from you as you're learning from them as you navigate your career. Mentor four is the anchor. And I had several anchors. When I was up and down in life and having a lot of problems, and I was the only hand surgeon here for 3 years and not sure if I wanted to stay at UVA, I had a few mentors that anchored me and made me realize what was important in life. And I was out of work-life balance and I was suffering in areas that were important to me, and they anchored me and brought me down to earth. And the reverse mentor is eventually, and this has happened to me, I'm the mentor, and then all of a sudden, I start learning a lot from my mentee, and the reverse relationship has developed. And this happened with me and Richard Dacus. Dr. Dacus I was a medical student when I was an attending, and he was my partner. He's been my partner for 16 years, and he's our vice chair for diversity, equity, and inclusion. And yes, I'm his mentor, but he is now mentoring me on areas of DEI, so I better understand it. And that's the reverse mentor relationship. And when you reach the point of a reverse mentor relationship, you've had a long-lasting mentor-mentee relationship where it's mutually beneficial to both people. And that's the ideal mentor-mentee relationship. So different individuals played these roles in my academic career. There's peer mentors, the mentoring, those are focused on specific skills and organizational success. Career mentors who advise me on choices and support with advancement. And there's life mentors who you form a long-term relationship, and they're your sounding board. So mentoring is a term that's thrown around a lot, but it's a complicated term, and it's very hard to have the right mentor-mentee relationship. And Coach Tiffany mentioned on the shoulders of giants, and it's not cliche, on the shoulders of mentors is what I really contribute my success to. Seeking mentors is the key to career success, and mentorship is crucial at all career stages. It doesn't matter how old you are. The delicate balance of mentoring someone is not creating them in your own image, but giving them the opportunity to create themselves. That's Steven Spielberg who said that. So mentorship exists in all occupations, right? But this is something that's very important. Of course, my dad was a pediatrician for 51 years. My mom is a TV personality in the DC area now, but they came from India with literally nothing. And they did what they can to support their kids. And they are my anchors always. When I was losing direction, I would talk to them and realize again what was important to me. Now, this man is a mentor to so many of us. And I cannot tell you how much he has meant to me and my academic career. This is why I chose academic orthopedics. This is why I came back to UVA in many ways, for many reasons. He led by example. He was a silent but powerful leader. Those of you who get to know him, you will see he doesn't say a lot, but when he does, you better listen to him because he's giving you some important advice. He worked harder than anyone else in the room, and he probably still does. And that's been I have tried to emulate him and walk the walk of all my faculty and residents and fellows and try to understand their issues by working hard. When I was a resident, I lived in fear of disappointing him, and I still live in fear of disappointing him every day because his example has really dictated in many ways how I've led my life in academic orthopedics. And I think many of you will share that. So Greg Degnan, who was on faculty for a long time, many of you know him. He's why I chose hand surgery. And he taught me how much gratification you can get from teaching. And it was really remarkable. And he is still one of the best educators I've ever come across. Dave Green, of course, my mentor, made me love hand and upper extremity surgery. He taught me how to take care of a lot of professional and college athletes because that's what his job was. And he said he learned from every fellow he trained, which was very unusual to hear someone so experienced and in an international reputation say that to their fellow. And he talked about lifelong learning, and he was an expert in communicating with patients. He called all his patients the next morning after surgery to make sure they were okay. Any big case he did, he called them every day at home to make sure they were doing okay. His level of communicating with patients is still some of the best I've ever seen, despite all the people I've come across. Chris Pederson was my mentor also at the Hand Center. He had no fear when operating. He never shied away from anything. And I learned from him, do not put your head in the sand when you have a complication. Address that complication head on. Dr. Densing is laughing because I think we had some board collections and stuff, and we were talking about this. But never put your head in the sand. And he's technically the most gifted surgeon I've ever worked with, and he taught me to love microsurgery. But he would always give me a hard time when I would say, well, I don't think the wound looks that bad. Maybe we just need to put him on antibiotics. And he's like, you're running away from the problem. This person has a surgical site infection, needs to go to the OR. Why are you minimizing this complication? Because you did that case and you don't want to admit that you have a complication? Probably. But I cannot emphasize, he told me, do not run from your complications. Of course, the icon and the legend, he gave me a job. I inherited his hand upper extremity sports practice. Why I love taking care of athletes. Realized how much, from him, I realized how much you can learn by observing. And it really is remarkable. I watched him do a lot of surgeries like many of us did, but his ability and the way he connected with patients was incredible. And his technical skills in his prime were just remarkable. And what I learned something simple from him, no matter how good you think you are, outcomes in surgery are yes, practice, yes, experience, for a large part, luck. He would tell me, you can do the perfect operation on the right diagnosis, and they could do great or they could do terrible. And part of surgery and taking care of patients is luck. And it's so true. And I think everyone who's an experienced surgeon will agree to that completely. Mary Beth Izaki, many of you don't know her, but she's kind of my second mom. I did my congenital hand training after San Antonio at Texas Scottish Rite, and she inspired me to include Peds hand and congenital hand in my practice. She had incredible patience in teaching residents and fellows in the OR, and her bedside manner is second to none. She is a complete role model to me with regard to bedside manner. Mark is not here today because he's president of AOSSM, and they have their presidential line board meeting today at Keswick. So I was like, just bring them all here. But he's, again, he actually catapulted my academic career. He gave me, as soon as I started here on faculty, he said, you're going to write like 12 book chapters this year for the Miller Review Machine or the Miller Orthopedic Review Textbook Machine. And he was all about lifelong learning and the persistence, never giving up. Gave me the opportunity to be part of this Miller Orthopedic Review and Textbook Machine, and is a large reason why I got promoted so early. He gave me those opportunities, and he supported me. So I'll forever be thankful. And then this man who is giving a lecture later today, what Dr. Abel did to me, I cannot express in words how it helped me develop as a leader. He appointed me vice chair in 2008. He gave me incredible responsibility, department finances, recruitment, faculty comp. He trusted me and let me make mistakes, and he prepared me to be a chair. And he let me make decisions and have difficult negotiations and conversations, which have helped me when I became chair here. Mark, and I don't say this enough, Mark, you have done more for me from a leadership standpoint than you will ever know. A lot of ASSH members. There's a lot of big names on this slide. A lot of friends who were mentors and coaches. Dan Osei and I have been friends a long time. He was our visiting professor earlier this week from HSS. But a lot of friends were there for me when I needed advice. And I needed someone to talk to me as a friend and not just another academic orthopedic surgeon or hand surgeon. And then I have several coaches. So on your left, Venkat and Rob Caraway and Isabella are three of my professors at Darden. So I spent a lot of time at Darden learning about leadership and organizational management. And I actually have, and I still meet with Venkat on a regular basis. And they're my coaches, and I call them for difficult problems. And I try very hard. If I can't figure it out or I'm lost and I have a specific problem I need to solve, I call one of them, and they're always on the phone, and they're willing to meet for coffee, and they are willing to sit down and help me navigate that. These are all short-term relationships, but it's coaching. And then Karen Ruban was my mom here in medical school. She's someone who gives me a very empathetic pat on the back when I need it. And I go to her frequently when I'm frustrated, particularly navigating politics and leaderships here. And the two people up top, you said, so Tony Bennett moved in next door to me when they moved to town 14 years ago, and we developed a close friendship, and so did our families. But Tony and I meet every month and have for 14 years over a cup of coffee to talk about how do you inspire people? How do you get the most out of them? How do you get people to perform? And it's become an incredible relationship, almost to a mentor relationship. And the picture next to him is his father, Dick Bennett, who's a Hall of Fame coach. Dick, every time he comes to town, 3 to 4 times a year, he takes me out to coffee and I ask him, what do I do? I don't know. These people are not performing well, or this situation, I need your help. And he's a non-physician, but they have a perspective on leadership and performance because of their careers that are very impactful to me and help me navigate a lot of issues that I run across. So that's sort of the mentorship aspect of it. But now I want to talk about the teaching aspect of it and how I've evolved as a teacher. So this was the course abstract if you looked in the syllabus. Resident and fellow education requirements have changed drastically over the last 2 decades. Duty hour restrictions, surgical milestones, technology-savvy students have made more traditional educational techniques less effective and even obsolete. Impactful teaching requires a continual adjustment to how residents and fellows learn. So this is very different. When I was a resident or student coming through, I just was lectured to, and then I was expected to learn and figure out how to learn. That's not how the world works now, and I'll explain why. So what's changed in resident education during my career? Generational differences, diverse populations. Didactic is being transitioned to case-based and active learning. The 80-hour work week, less exposure to cases in certain situations, number of cases at graduation in certain situations, shift work, night float, day float, afternoon float. I don't know how many floats we have now. Case minimums. Now, instead of you have to do minimum cases to be minimally competent. So it's not do as many cases as you can to get good at something. Here's the minimal number of cases you can do to be minimally competent. It's a very different way to approach things. It's about saying, let's get down to the lowest level of competence rather than saying we should be trying to achieve the highest level of competence. It's a very different approach than many of us have come through. COVID-19 pandemic, virtual conferences and meetings, and simulation. Those are major changes that happen in resident education during my academic career. And many of you have experienced this, and many of you threw in the towel. I mean, when the electronic medical record came around, a lot of more senior surgeons, physicians threw in the towel and said, I'm not going to learn this, right? So you have to adapt to all these changes. Otherwise, you will not be successful as an educator. So how I used to teach. Death by PowerPoint, right? We've heard a lot of PowerPoints. You're listening to me teach from a PowerPoint. This is how we all taught. Most of us in this room learned by listening to someone lecture, and then we got to figure out how to do this. That's not the best way to learn. And I'm going to go over the difference. There's 3 different types of teaching. So Socratic method, didactic method, and then self-learning, okay? So what's the best way to teach? And I was failing miserably as a teacher about halfway through my career because I was sticking to the didactic way of teaching and I wasn't connecting with my learners. And I think we all struggle with that because we weren't willing to change the way we teach. And even though our learners learn differently. So Socratic is an active method of learning. The teacher does not provide information, but asks a bunch of questions. It's pimping, right? A lot of us learn by the Socratic method because when we're on rounds or in conference, we were pimped. Pimping is a transformed, ill-intentional version of a time-tested teaching method designed to embarrass the learner and reinforce medical hierarchy rather than promote learning. That's the disadvantage of the Socratic method, and I am guilty of this many times over, and so are most of you in this room, I would guess. Right? So this is just a, these seats are really hard. What is hard? How can we know? Well, it sure feels hard, right? So, I mean, this is the Socratic method. You have to think, you have to figure out what the person asking the questions is thinking. So there's been some studies, and I've reviewed a lot of medical literature, academic medicine journals to figure out what's a good way to learn to teach. And this was fourth year medical students on their internal medicine clerkship. 97% faculty, 89% faculty felt that the Socratic method was a good way to teach. 39% of students felt humiliated during the teaching process, but only 14% of faculty, but only 14% wanted faculty to stop asking questions. So they were humiliated, but they understood the effectiveness of that way of teaching. They didn't like it, but they knew it was effective in some scenarios. So the takeaway from this article was authors speculated that explicitly stating the purpose of probing questions may result in better reception by students. So direct them before you ask the question, so they have an idea of what you're thinking. Benefits and detriments. Benefits: it promotes self-directed learning, engages the learner in critical thinking and thinking on one's feet, which is critical for medicine. And learners have an immediate access to an expert. The person asking the question is the expert, right? The detriment leads to embarrassment in a group setting, and it's more time intensive, and you can only cover a limited amount of material. So it's not an efficient way of teaching. Didactic method, which we all live through and you're living through right now. It's a method of learning by which a teacher presents information directly to the learners via structured lessons that focus on lectures. Learner receives information in a passive manner. So right there, that word passive tells you that it's an ineffective way of teaching. But yet we have all learned this way. Learners enhance their understanding by asking questions of the lecturer. So again, death by PowerPoint. This is what we live through on a regular basis. So again, looking at some of the academic literature, and this was out of the radiology literature, didactic versus Socratic method, learner perceptions from the literature. 93% of students preferred Socratic style of learning. Students prefer questions designed to help develop an understanding, but they felt that questioning helped them realize knowledge gaps and it gave them daily pressure to come prepared. So active learning was preferred over passive learning by students. So that's the advantage of Socratic teaching, is it's active learning. Didactic teaching is passive learning. So they each have their benefits, right? Here's the benefits of didactics. It's efficient, useful to disseminate a large amount of information in a brief period of time to a large audience. But there's a detriment. It's passive. It's passive. Students are not asked to manipulate the information, and you don't know if they actually understand the information that you're presenting because you never have an opportunity to quiz them on it or test them. But if you question, so the problem is that you don't know how deeply the students understand the presented material. Self-directed learning. This is the third type of teaching. This is where the student engages with material at the own pace. The learner takes initiatives to diagnose their learning needs, and they identify material, human and material resources to implement their learning strategies. So this is how self-learning works. So self-directed learning, as a teacher, you establish their learning goals. Then you help them locate and access resources. They figure out they're going to learn, and your job is to monitor and evaluate their performance and reassess whether you should change their learning strategy. And this is again from some medical literature where they looked at medical students, control groups using surgical curriculum, and then a video group looking at a video-based surgical curriculum. Students in the video group indicated a greater increase in self-reported surgical knowledge and a greater increase in objectively tested surgical knowledge. So the conclusion from this paper was guiding students in their self-directed learning endangers engenders greater confidence in knowledge, increase and objective increase in knowledge over a standardized curriculum where they're lectured to. Benefits: learners choose the method and pace by which they learn, and they can tailor their educational experience. It promotes the framework of lifelong learning, and teachers feel less encumbered by the need to cover everything because there is an expectation that the learner actually spends time learning before lectures and before cases and before surgeries. The detriment is you cannot know what you do not know, and it requires a lot of self-motivation. So the conclusion from the teaching standpoint is learner engagement is paramount. An unengaged student is not learning, number one. And each teaching and learning technique has utility. Understand the strengths and weaknesses of each technique, and of the learner's will inform which technique to use. So the goal as an effective teacher is to use all three techniques and figure out what is the best for your audience. So this is an example that was given for teaching hand anatomy to first-year medical students. Start with providing a list of resources that they can peruse during self-directed learning. Then have a large group didactic learning session where students come prepared with questions from their pre-reading, and then use the Socratic method in small groups in the anatomy lab, but you outline to the students the purpose of the question so they can apply their knowledge in a clinically relevant context. This is the most effective way of teaching our current learners, and it's a combination of all three techniques. So let's talk about work hour restrictions. So again, I'm talking about the changes, and it's only about 5 more minutes in my talk, but a lot of things have changed, and how do we adjust to this? So the advantage of work hour restrictions are better work-life balance for residents, which is important. This is Ann Van Heest, who led this initiative to look at the effectiveness of work hour restrictions. The disadvantages are decreased clinical contact time with increased amount of knowledge that need to learn. So 90% of residents now do fellowships, and that is thought to be because it's difficult to go into a practice without an additional year of training. So we see that now. And is it because of work hour restrictions? Hard to know. Work hour restrictions have not led to higher scores on exams, which was the original intention. One study showed in the ACGME national database, no statistically significant change in orthopedic in-training exam scores, but there was an increase in total number of cases performed after the 2003 restrictions were implemented. So that was a good sign. But the board failure rate has slowly gone up. And this was data from 2006, 2010, and it's actually gone up higher. So it's in the low 20s now, is the overall board failure rate. It used to be 13% in 2006. So is the work hour restrictions helpful or not? I will say that, of course, it's helpful, work-life balance. I would say we're failing as teachers because we're not engaging and connecting with our learners, and that's why the failure rate is going up. Because we are using old styles of teaching still when our learners don't learn that way. You cannot run a residency program the way you did 10 years ago and do it in 80 hours a week. This is Bill Levine out of Columbia. Residency program directors, department chairs, and faculty, you see, it doesn't say residents, have to become more efficient in the way they educate. Every hour should be valued as a critical hour in the residence week. And if it's not serving a strict educational purpose, then we need to do things differently. And the other thing that's changed, and all of this, I think, has an influence on how to be an effective educator. I mean, I just went to the library and looked at the books when I needed to look some up. If you go to the health system library now, there's no books anywhere. There's 0 books in the library. It's a library with 0 books because there's computer screens, there's this, there's that. Today's trainees are tech savvy. They have low dependence on textbooks and paper copies of journals and articles, and they have significantly higher reliance on PubMed and electronic access for textbooks, articles, and videos. Faculty members need to consider social media. I'm the worst with this, but I know there's a lot more that are much worse in this room, but social media is a large part of trainees' lives when teaching them. So we as educators need to realize that they learn differently than we do, and we have to develop teaching methods that work on computers or on an app, develop ebooks instead of the good old-fashioned textbook. And that's Lisa Canada. And the other thing that has been a major change is simulation. And Winston has done a phenomenal job. I want to give a shout out. I was residency director here. I can tell you that compared to what Winston's did, I was a shitty residency director. I mean, Winston has elevated the education of this program to a level that has been it hasn't been seen before. And I can say without question, he's the best residency director in the country. And I know a lot of people will agree with me on that. So one intention of work hour restrictions was to decrease the amount of time residents spent in service and increase the amount of time spent on educational activities. Part of those activities is trying to get a structured curriculum and trying to teach a certain amount of surgical skills prior to even getting residents in the operating room. So that's simulation. So our interns do a simulation curriculum. We have, when you get a chance to go upstairs, we have a bioskills lab upstairs. We have a cadaver lab. Simulation is critical, and you need to get them started in simulation the minute they hit the door as an intern, even before they start doing cases in the operating room. So ABS now requires residents to complete surgical simulation training. 7 programs in the country are working on curriculum design and surgical simulation to teach and test surgical skills. Ann Van Hees, University of Minnesota, does a tremendous job of this. But they also need dedicated simulation space. So I invested upstairs in a simulation space, and we have a big cadaver lab for that very purpose. And this was the counter view on that by Bill Levine, is that we hope that simulators do not take the place of actual one-on-one interaction with faculty mentors and surgeons who help train the residents through the mentorship model. Residency should always be an apprenticeship model where faculty take pride in teaching a resident on improving their skills. So we can't leave it up to simulation. So in conclusion, so what have I learned in my 22 years on faculty? Mentors are the key to career success, and choosing the right mentor is critical, and it takes a lot of thought to find the right mentor. And I gave you the tools to look at and what you should be considering when you're identifying your mentor. It should be a long-term relationship where both of you benefit. Case-based teaching and active learning are the most effective ways of teaching this generation of learners. Learners are tech-focused and learn better if teachers use non-traditional resources, digital tools, social media, ebooks, online videos, simulation. Us older faculty need to figure out how to use this in this way we teach. We can learn something from everyone, and Dave Green taught me that. And this is a great quote by Chris Hadfield from the business world. Every single person you ever meet is an expert in something that you aren't. So what does that mean? You can learn from everyone you come across. Learn from your students, learn how they best learn, and change the way you teach, and you will be a more effective teacher and mentor. I cannot emphasize that more. It is up to the educator, not the learner, to figure out how to best teach. Don't affect them. Don't expect our learners to figure out how to best learn. It's our responsibility to figure out how to best teach. And this is not just academics. This is everyone. You got to best teach your surgical tech or your clinic nurse or your MA. It doesn't matter. You have to figure out how to be an effective teacher. Teaching, coaching, and mentoring is an active process and should always be flexible. Do not become stagnant in how you teach, or you will be ineffective and irrelevant. Continue to adapt your teaching style and method. Thanks to the fellows and residents, I've trained over 100 orthopedic residents and now 32 hand fellows. Of course, my faculty and alumni, am indebted to all of you for helping me really push our culture and our vision forward. And of course, my wonderful family who put up with a lot of the fact that I was never around and was always sometimes challenging to deal with. But they're all in college. My kids are in college now, so empty nesters, so getting adjusted to that. And then, of course, this is my pride and joy, this orthopedic center, and I'm so glad you all are here to see it this weekend. So happy to answer any questions. I have about 5 minutes before lunch, so I hope that was interesting enough. I know it was a very different talk, but I really think it's on the onus of the educator to figure out how to best teach. Thank you. Any questions, thoughts? Otherwise, we can go get our picture first and then lunch outside.